Good afternoon, everybody. Welcome to the academic Zoom meeting of the Department of Pediatric Surgery in East London. And today we are going to discuss about cystic fibrosis and the pediatric surgeon. Our medical officer, Dr. Conita Sali, will talk about it. And we are very lucky that we have Professor Sam Moore as our invited guest today, but we also have Dr. Maurice Levy. Let me first introduce Professor Sam Moore. Professor Moore studied at the University of Cape Town. He then did a fellowship FRCS from Edinburgh in 1976. Then he worked for 7 years in Lesotho before he did his full training as a general and then as a pediatric surgeon through UCT, Krutoskir and Red Cross Children's Hospital. He joined University of Stellenbosch in the 1991 as associate professor and was soon promoted as a full professor in 1995, where he continued to work as head of Department of Pediatric Surgery till he retired in 2013. In addition to being an experienced and qualified general and pediatric surgeon, Prof. Moore has lots of achievements, and a few of them are Sachs Prize in Surgery, Arnold Katz Prize in Pediatric Surgery, but I think the most important of them all is the Denny Brown Gold Medal by the British Association of Pediatric Surgeons given to him in 2014. And to my knowledge, very few pediatric surgeons who practice outside the United Kingdom have been bestowed with this honor. Prof. Moore was a past chairman of the South African Association of Pediatric Surgeons. He has been a member of the Council of the College of Pediatric Surgeons of South Africa, and he has over 200 publications, more than 3,500 citations, and more than 100 presentations in international conferences. So, Prof, we are very lucky and very pleased to have you. Our second guest is Dr. Maurice Levy, who is a senior retired pediatrician from the Frere Hospital in East London. And he has been our colleague since the day we started in East London, that's 1st of February 1995. And Dr. Levy had a special interest in cystic fibrosis, and he ran the cystic fibrosis clinic in Frere Hospital for almost 4 decades. So he has significant experience and will have lots to offer. Prof. Hadley, who used to be in Durban, is also with us, as is Dr. Dayo Avotedu, who is a pediatrician who works at Cecilia Makiwane Hospital with special interest in allergy and related disorders. So without much further introduction, I will ask Dr. Sali to share her screen and give her talk about cystic fibrosis and the pediatric surgeon. Conita?
Good afternoon, everybody. Can you see my screen, Prof?
Yes, we can see your screen. Maybe you can speak a little bit louder, that's all.
Okay, our talk this afternoon is on cystic fibrosis and the pediatric surgeon. So thank you, everybody, for attending today. Cystic fibrosis is an autosomal recessive disorder, and it manifests as multi-system dysfunction. It was first described in 1938 and is the most common lethal genetic disease in Caucasians. Its incidence is around 1 in 2,000 in North America and Europe, predominantly in white populations. In South Africa, the carrier rate is 1 in 23 for the white population and 1 in 55 for those of mixed race. Cystic fibrosis in the South African Black population remains low to this day. Patients typically present with intestinal obstruction or malnutrition and die from overwhelming pneumonia within the first year of life. Between 1955 and 2005, the median survival of patients with cystic fibrosis has increased dramatically from 6 years to 36 years. The improvement in the outcomes in patients with cystic fibrosis is largely due to advances in antibiotics, nutritional approaches, and the collection of clinical expertise at specialized treatment centers. So cystic fibrosis occurs as a result of a mutation in the cystic fibrosis transmembrane conductance regulator gene, which codes for the CFTR protein. The CFTR gene is located on the long arm of chromosome 7. The mutations on this gene are classified into 5 major classes. Classes 1 to 3 are considered severe, as indexed by pancreatic insufficiency and high sweat sodium chloride values. And classes 4 and 5 are considered mild, associated with pancreatic sufficiency and intermediate or normal sweat sodium chloride values. There are over 1,900 mutations in the CFTR gene that can cause cystic fibrosis, but the most common is the delta F508. The cystic fibrosis transmembrane conductance regulator is found in the epithelial cells of many organs, including the lungs, liver, pancreas, digestive tract, reproductive tract, and the skin as well. It's mainly found in exocrine glands. The regulator functions as a cyclic AMP activated ATP gated anion channel, and it increases the conductance for certain anions, such as chloride, to flow down the electrochemical gradient. So ATP-driven conformational changes occur in the regulator in order to open and close the gate to allow for this flow of anions. The regulated protein is a chloride channel that's found in epithelial tissue. And as I mentioned, the ions are driven against its concentration gradient using ATP. When the CFTR protein is defective, it results in disruption of the chloride ion movement and affects sodium reabsorption. This reduces the amount of fluid in secretions, thereby resulting in reduced airway surface liquid. Ultimately, it results in an impaired mucociliary escalator, impaired mucus clearance, and poor immunological function within the respiratory tract. There is now opportunity for bacterial growth in a host with impaired immune function. Cystic fibrosis therefore results in a pro-inflammatory cascade that contributes to multi-system dysfunction. So with regards to the pathophysiology in the pancreas, in utero, there's pancreatic duct occlusion resulting in fibrosis and permanent scarring. This leads to impaired exocrine function and pancreatic insufficiency. As the child ages and approaches their preteen years, the endocrine pancreatic function is also disturbed, and these kids then develop diabetes secondary to their cystic fibrosis. In utero, the thick mucus produced by the small intestine can cause the meconium plug, resulting in distal intestinal obstruction. It can also cause cholestasis leading to neonatal jaundice and cystic fibrosis related liver diseases or liver disease a bit further down the line. Not really related to kids, but in men, 98% with cystic fibrosis are infertile due to congenital absence of the vas deferens. And in women, the poor nutrition in cystic fibrosis is an important contributor to difficulty in conceiving. One needs to be in mind that the timing of pregnancy should be carefully planned, as it's often associated with deterioration in lung health. So with regards to presentation in neonates, Meconium ileus in the neonatal period, 10% of children with cystic fibrosis present with abdominal distension, delayed passage of meconium, and bilious vomiting in the first few days of life. There is an accumulation of very thick, viscous, inspissated meconium, which leads to these features of obstruction. Cystic fibrosis may also cause appendicitis in the neonatal period due to the nature of meconium as described previously. Babies may present with failure to thrive or prolonged jaundice resulting from cholestasis. It's also important to note the difference between simple and complex meconium ileus. So simple meconium ileus is when there's thick impacted meconium at the terminal ileum. Usually 60 to 70% of simple meconium ileus responds to and is relieved by water-soluble contrast enemas. Complex meconium ileus is complicated by additional GIT pathologies, such as intestinal atresia, necrosis, and perforation. And the perforation then results in a sterile meconium peritonitis. Complex meconium ileus requires more invasive treatments such as evacuation or resection and enterostomy. Presentation in infancy, so patients may present to you as failure to thrive, recurrent chest infections, pancreatic insufficiency and steatorrhea, or intussusception. And in childhood, as kids get older, rectal prolapse is a hallmark in 10% of patients with cystic fibrosis, but they may also present with nasal polyps and sinusitis as well. In adolescents, they may present with pancreatic insufficiency and diabetes as previously described, chronic lung disease, distal intestinal obstruction as well, and gallstones and liver cirrhosis. Now, looking at diagnostics, NHS in the UK has made it mandatory for newborn screening for cystic fibrosis, and this has been in place since 2007. So immunoreactive trypsinogen is measured on a dry blood sample on a Guthrie card on the 6th day of life. And abnormally raised immunoreactive trypsinogen will undergo CFTR mutation screening, and then also it will warrant a sweat test. The sweat test is the gold standard for diagnosis of cystic fibrosis. It has a sensitivity of 98%, and the test must be collected on 2 occasions. Molecular diagnosis with full genotyping should also be considered for screening other family members and for prenatal diagnosis in future pregnancies. Stool elastase may also support your diagnosis of cystic fibrosis. It is found to be low in these patients with cystic fibrosis and pancreatic insufficiency. So normally, normal stool elastase will be more than 200 micrograms per gram of stool. In severe cystic fibrosis with pancreatic insufficiency, it'll be less than 100 micrograms per gram of stool. And mild to moderate pancreatic sufficiency ranges between 100 and 200 micrograms per gram of stool. So with regards to treatment, mucus clearance, the patient will require chest physio for postural drainage, and nebulized hypertonic saline may also be of benefit. It's important to control any infections, so prompt initiation of antibiotics, ideally culture directed, at a higher dose is required to treat respiratory tract infections. Bronchodilators should be used with caution, as this may lead to submucosal gland hypertrophy and a hypersecretory state. However, corticosteroids should be avoided. Additional treatments include mucolytics, expectorants, and cough suppressants. These have also been used to relieve respiratory symptoms. With regards to nutrition, most patients with cystic fibrosis will require pancreatic enzyme replacement to aid absorption, as well as nutritional supplementation and daily fat-soluble vitamins. In the long run, lung transplant may be considered for respiratory failure. It is of utmost importance that we remember the emotional, social, and psychological aspects of patients with cystic fibrosis as well. The patient's attitude regarding the illness and their treatment will ultimately determine their compliance. So we've already alluded to a few scenarios where we as ped surgeons may be needed to assist in the management of kiddies with cystic fibrosis. So kiddies with cystic fibrosis receive a significant number of abdominal surgeries for various indications compared to much fewer pulmonary surgeries. When a baby presents with a delay in passage of meconium, it's important for us to have cystic fibrosis as a possible cause for this in our minds. As mentioned before, cystic fibrosis may also be the cause of appendicitis, which may occur in the neonatal period and which needs to be recognized. Interestingly, the perforation rate in cystic fibrosis is 80% compared to the general population of 19%. People with cystic fibrosis also have more uncommon consequences for the appendicitis, such as chronic abscess formation resulting in appendicular cutaneous fistulae. An interesting side note is that the non-inflamed distended appendix itself may also act as a lead point for intussusception. It has also been said that there's a correlation between cystic fibrosis and jejunal atresia, where cystic fibrosis acts as the predisposition. So we may be presented with patients with cystic fibrosis with chronic abdominal pain, and this is mostly due to malabsorption. However, close to 50% will present with varying degrees of recurrent obstruction. So when there's evidence of obstruction, we may need to get involved in order to relieve this obstruction by evacuating the inspissated stool. All the while, we need to recognize the importance of preserving bowel length and the restoration of the GI tract itself. The initial procedure of choice is the insertion of a T-tube enterostomy and the post-op administration of a lytic agent such as N-acetylcysteine. So the T-tube ileostomy involves placing a surgical T-tube in the bowel to allow for further washouts post-op. A benefit here is that it can be removed later without an operation. There are also 3 other procedures that have been described in cystic fibrosis, naming the Bishop-Koo, Santulli, and Meconium double barrel ileostomy. So Bishop-Koo ileostomy may also be considered to evacuate the stool, as well as the installation of lytic enzymes distally. This procedure involves dissection of the segment of ileum containing the mass of meconium. The distal ileum is brought out as an irrigating and decompressive ileostomy, and an anastomosis is created between the side of the distal segment of bowel and the end of the proximal segment. Both the T-tube ileostomy and Bishop-Koo procedures have compatible results. In the Santulli procedure, the proximal bowel is used to fashion a stoma and anastomose side to end with the distal bowel. And in Meconium's procedure, one essentially fashions a double barrel stoma. So over the past few decades, there has been significant reduction in mortality in neonates who present with Meconium ileus from 50% to close to 100% survival. However, by the age of 10 years, 50% of kids with cystic fibrosis still die from respiratory failure. That being said, kids with cystic fibrosis are in fact living longer than before, and we are naturally seeing more complications as a result. And this is where we as ped surgeons are required to assist with management. Thank you.
Konita, thank you very much. I know the two of us have gone through this presentation a few times, but I think it was a very good presentation, and it was just the highlights, and so thank you for the presentation. Now I will invite Prof. Moore to give his advice, his opinion, his experience. And what prompted me actually to read more about cystic fibrosis was when I was preparing for my college exam in 2003, 2004, I had read this editorial by Prof. Moore in the South African Journal of Surgery about the pediatric surgeon and cystic fibrosis. So I think that I remembered, and I still had the copy which I gave to Konita. So Prof, you can share your screen, and you can start your giving your advice. We have about 20 minutes for you.
Yes. Are you seeing my screen there?
Yeah, we can see. If you can just go to from the beginning. If you can click on the slides from the beginning.
From the beginning, it's on the left-hand side. Yeah, there you go. Okay. So, and can I make it full?
Just you need to click on that from the beginning, Double click. Yeah, okay.
Okay.
Yeah.
So my task was to talk about the surgical aspects of cystic fibrosis, and I will congratulate Juanita on that presentation. It was very good, and I actually learned quite a lot. So, but I will stick around more or less what how it applies to the pediatric surgeon, and certainly take you through at least one case. So things often start with meconium plugs, and they're not uncommon. And they can be associated with prematurity, a diabetic mother, or certain drugs in pregnancy. But I just want to bring your attention to Hirschsprung's disease, because in our series on Hirschsprung's disease, there were numerous cases where there'd been a meconium plug which had been washed out, everybody thought it was fine, and nobody did anything more, and then the trouble started. And of course, cystic fibrosis is one of the differentials. And in this context, one of the things you can do in every patient with a meconium plug is to take a family history as far as you can. And having said that, I'll walk on to cystic fibrosis. Oh dear, this is not coming out very well. Okay, I don't have to say too much about cystic fibrosis because Juanita has covered it, and she's covered the etiology very nicely, and that it's to do with the secretion of chloride, part of the chloride channel, and it affects mainly the respiratory and the gastrointestinal tract. Just to mention, I'm sure that Dr. Levy will mention this, but there are some very interesting treatments coming into the picture in recent times, and many new drugs, which are very specific. And that's one of the reasons why we need to know about the actual genetic background, because the drugs can be specific to the background. But if we look at Meconium ileus as a subject, often the surgeon will be presented with a child with neonatal obstruction. This child has obviously got neonatal obstruction. There may be a history of polyhydramnios. The child may be premature. And as Juanitas said, there was a simple or complicated form. In the simple form, there's thickened meconium, which obstructs usually in the mid-ileum and also in the terminal ileum, causing proximal dilatation, bowel wall thickening, and congestion. And of course, the family history is the one that counts. So usually in the simple Meconium ileus, it presents 36 to 48 hours after birth. And there's failure to pass meconium, or there can be meconium pellets or plugs. And of course, because it's obstruction, there's bowel stain vomiting, there's abdominal distension, and again, the family history. Now, what the, sorry, I've just got to move the sign, my picture. Here's the, oh, sorry, no, up one, sorry, there. If you look at this X-ray, which I think is the picture of that particular child, you will see that there's a large amount of meconium and down in this corner here, and it's there are dilated loops of bowel, which you can see clearly in the lateral, and they're in a concentric pattern. And the interesting thing is that if you take serial X-rays, the loops do not shift. And you can see air bubbles in the dilated small bowel and what they describe as a ground glass appearance. Now, it's a coarse granular appearance. Ground glass is usually found in loos, in toilets, windows, bathroom toilets. I'm just struggling to get this picture of all of us out of the way. Now, this is the contrast enema on that particular child. We always used in the past gastrographin, but it never gave good pictures. And so many of the modern radiological agents that they use contain meglucamide. And in this one, you can see there's a small unused colon. And down here at the ileocecal valve, you can see the dilated ileum starting there with these pellets in it. It's actually shown quite nicely in this picture. Then, of course, there can be complications, and as Juanita pointed out, volvulus is one of the more common ones that we get. Certainly, jejunal treat. Oh, sorry. Okay, I hit the wrong button. Yeah. And Meconium peritonitis, she talked about. And then, of course, if you get perforation, you can get the Meconium cyst that can occur. If you don't relieve the obstruction by either injecting water-soluble material or else contrast enema, you have to operate to relieve the obstruction. If there are any of the complications, you have to operate. And just remember that any surgical procedure may have respiratory post-op complications, particularly respiratory plugs. That was our experience, that very often they had recurrent atelectasis as a result of plugs in the respiratory tree. Well, how do you treat Meconium ileus? Well, you first got to, if you've got a patient with a neonatal obstruction, you have to resuscitate the patient and do a therapeutic contrast enema. And if there are complications, obviously you need to do surgery. Now, we talked about the T-tube, and I'll show it to you in a moment. But the whole idea of the surgery is to give access to the bowel so that you can instill lytic agents. And N-acetylcysteine is the one we currently use. We mentioned the Bishop Koop distal chimney ileostomy, and that if you look at this diagram, you'll see that the proximal dilated bowel is anastomosed onto a distal chimney. So your catheter will come in to this distal chimney and instill the N-acetylcysteine, and the continuity of the gastrointestinal tract is maintained through that anastomosis. This needs an operation to close it when you are ready to do that. And it's a fairly simple operation of actually just closing this part of the chimney, and then the anastomosis will function. And it looks on the abdominal wall just like a stoma. But the T-tube, I think, is an advance. But there's certain things you have to know about it. It has a distinct advantage over non-operative closure, non-operative closure following removal, and Juanita made that point. And you can put the lytic agents in through the T-tube to wash out the bowel. The first point I'd like to make is the obstruction must be relieved before you put in the T-tube, because we had, I think, one or two where this was not done, usually by a registrar, and the obstruction remained. So you have to, I think, usually manipulate with your fingers the pellets through into the colon and try and wash them out of saline as you go. The down here you'll see that the T-tube has got a short side and a long side, and that's quite important because you want the bowel, the N-acetylcysteine to flow down the bowel, and so that's quite an important part. There's no real difference in the results between the Bishop Koop and the Michelix or the Santilli procedures. The Santilli is basically just a reverse of the Bishop Koop, and it's a sideways anastomosis, not an end-to-side anastomosis. So the results are more or less the same. And as Juanita has said, there are a lot of problems in these children. Intussusception can occur, rectal prolapse can occur, they can reflux and have esophagitis, and then of course you've got all the problems with the pancreas, with the biliary tree, and the bile duct stenosis is actually quite interesting because it's usually due to pancreatic fibrosis. As you know, the distal bile duct goes through the head of the pancreas. And then you've got cirrhosis of the liver with malnutrition and vitamin deficiencies and hypernutrient deficiencies and fecal. Sorry, was there a question?
No, Prof. No, go ahead.
Okay. And in fact, when we look at the outcome and the survival in South Africa, it's a lot lower than Dr. Levy can correct me, but I've seen a figure of 21 years as opposed to 36 years in other countries, and in 21 years for South Africa. And the South African, of course, very few lung transplants are done, whereas in other countries, I know of one friend of my daughter's who had 2 lung transplants and managed to survive for a number of years. So the long-term median survival is currently 20% in females and 30% in males, and continues to improve. And the 10-year survival is somewhere around in developed countries, 72%. And I think that's more or less what I want to say on this. It's a pity we can't take questions.
No, we will take questions. Yeah, we will take questions.
Okay.
No, I think this was excellent, Prof. I think you highlighted more about the surgical aspects and the surgery for cystic fibrosis. So this was really complementary to what introductory talk Juanita gave. So what I would do is now I will request Dr. Maurice Levy, who has been a pediatrician who ran the cystic fibrosis clinic here for almost 4 decades, to give his comments. Maurice, please unmute yourself and give your comments.
Hi there, can you hear me?
Yes, we can hear you nicely, Maurice. Go ahead, please.
Presentations. My interest is the misdiagnosis. Now, I don't think all cystic fibrosis kids will present with Meconium ileus. And because there are, as Juanita was saying, over 1,000 different genetic variations, you will also get so many different variations in severity of cystic fibrosis. And Prof. Moore was saying that our success rate is not as good as overseas, and that may be because they are picking up more of the milder cases and getting a success that's better than our rate, because we pick up only the very severe cases. So, you know, my experience has been of missed cases being picked up fairly late. For instance, a 4-year-old girl was picked up because she had a respiratory tract infection with Pseudomonas. And when you get an infection with Pseudomonas, you have to think of cystic fibrosis as number one to exclude. And another 6-year-old boy who we admitted with asthma, and we then found that he was quite malnourished, quite underweight, and we examined him and he had a scar on his abdomen, and that turned out to have been Meconium ileus, which was operated on. And he turned out also to be cystic. And then, so we have had mild cases who we have had difficulty in establishing cystic fibrosis, sent down to Cape Town with all the symptoms of cystic fibrosis, but they could not prove it. He had a sort of a borderline sweat test, and was treated with Creon, the pancreatic supplement, to a great success, and also had symptoms of asthma. But as we know, there are like 1,000 different genetic variations. So it's been very difficult to prove whether or not he has cystic fibrosis. The oldest person that I had treated was 35. We got him to the age of 35. And he was married. He had adopted children. And we treated him intensively with chest physio. And as I say, we got him through to the age of 35. And eventually he was admitted to St. Dom's and passed away. So we have been able to treat children and get them to an older age. The one child who had the Meconium ileus and then asthma, the 6-year-old is now in his late 20s. And he's a very mild case. What really interests me as well is the new treatments. There are 2 drugs, the ivacaftor and lumacaftor, which the one is a controller of the cystic fibrosis transmembrane conductance regulator gene, and the other one is a potentiator of this gene. And they, in children who have the delta F508 variant, can be used to successfully treat children with cystic fibrosis. The other very interesting treatment that's is the CRISPR, which is where a virus infects a bacteria, and the bacteria is able to make copies of the viral DNA and make an RNA which will actually chop up the viral DNA, and thus it's now been discovered that you can insert genes into chromosomes, and this may lead to genes being able to be inserted into the genetic material of a child with cystic fibrosis, and thus correcting the child's completely. But that's for the future. Also, in the history of cystic fibrosis, it goes back perhaps 1,000 years, where children were bewitched, thought to be bewitched, and they were, when you touched them and licked your fingers afterwards, they were found to be very salty. And the history of cystic fibrosis was very interesting to me.
Hello.
There is also a prenatal diagnosis where parents, from a buccal smear, you can get their DNA from a parent by buccal smear when you suspect cystic fibrosis by looking at the ultrasound, an ultrasound picture of the bowel on prenatal ultrasound is echo bright, and that may indicate the child or the fetus has cystic fibrosis. And buccal smears can then be done on both parents to see if they're in the carrier state. That's another very interesting subject.
Maurice, have you finished your comments?
Yeah, well, if any questions, yeah.
No, we will. There are some questions being typed in the chat box, so I will certainly get those questions. Maurice, thank you. You have given a pediatrician's perspective and also told us interesting facts about history and early diagnosis, and
Yeah.
And also about recent advances in the treatment. I distinctly remember about 10, maybe 15 years ago, we had treated a 10-year-old boy who was operated by general surgeons before we came to East London, and he had small intestinal atresia, secondary to Meconium ileus, which was resected and operated, and you used to follow him up. He also had psychiatric problems, and at that stage he presented to us with intestinal obstruction because of bezoar. He used to eat pieces of the carpet in his house, and we operated on him, and so that just a case of complicated Meconium ileus who presented later with intestinal obstruction. So thank you, Maurice. Prof. Hadley has a comment to make, so I'll ask him to make a comment, and after that I'll ask the questions posed by the attendees. Prof. Hadley, please go ahead.
Thanks, Professor Chitnis. I actually don't have a comment to make. I have a question to ask Dr. Levy, please.
Yes, yes.
Is the prevalence of this condition or these genetic abnormalities in South Africa sufficiently high to warrant a screening program? I suspect probably not, but is there a threshold of prevalence at which a screening program becomes worthwhile? Because if, as you say, our results lag behind countries that do have screening programs, is that an approach we should be looking at? Thanks.
I guess it should be a screening program in certain population groups. That would be my answer.
Do we know what the prevalence is amongst South African Caucasians?
It's 1 in 25 carrier state, and 1 in about 2,500 kids. So the carrier state is 1 in 25, but the actual incidence in children is about 1 in 2,500.
So Maurice, that is not very low incidence, because many of our other obvious congenital abnormalities, which we see and operate, the incidence is about 1 in 3,000 to 1 in 5,000 live births. So,
Yeah.
so it is not very low.
No, that's right.
And
I think in black kids, yeah, but Juanita's already mentioned that in the black kids, it's 1 in 55 to 1 in 60, the incidence, or carrier state.
Carrier state. Okay. There are some interesting questions. I think there's one question from Dr. Kirsty Pedersen, who is our medical officer. Is there a link between cystic fibrosis and biliary atresia? Maurice, maybe you can answer that.
Well, no, but they can present with inspissated bowel syndrome.
Yes.
Yeah.
And can mimic a diagnosis of biliary atresia, isn't it?
Yeah, they mimic a diagnosis, sure.
And the future course could be similar, that it could result into liver cirrhosis, biliary cirrhosis.
Correct, yeah. And portal hypertension eventually.
Portal hypertension, yes.
Yeah.
So there's another interesting question from Dr. Majola, our consultant. Does the use of ibuprofen have any benefit in these children?
According to what I've read, it does, but in lowish dose, because a high dose, it's got to be a certain dose, but it does help. A high dose of ibuprofen will cause pro-inflammatory situation, but a low dose is supposed to be quite useful.
Does that act as a mucolytic?
I can't answer that.
Okay. But for inspissated meconium, isn't it?
Yeah.
Okay. There is another question from Dr. Majola, that Juanita mentioned 5 classes, but the journals mention 6 classes. So Maurice, maybe you can answer that. Is there a 6th class?
Yeah, there are 6 classes.
Okay. But that just depends. I mean, they explain the severity of the condition, isn't it?
I think they're all quite severe.
Yes. Okay.
But depends on the treatment. Class 2 is the one that's amenable to treatment.
Okay, okay,
Um,
okay.
I have the list of
The classes.
classes. Yeah, I'm just
Okay,
looking
okay.
for them.
There's a
But,
question for Professor Moore. It's from Dr. Dio Avotedo, who is one of our consultant pediatricians with special interest in allergy. She works at Cecilia Makiwane Hospital. Prof. Moore, Dio asks, do we perform T-tube enterostomy? She's asking me. So Dio, not particularly. We see few children with really inspissated meconium resulting due to cystic fibrosis. So my answer to that is not particularly, but I will invite comments from my other consultant colleagues also. And what is the success rate as a standalone operation as a T-tube enterostomy as compared to the more invasive operations? I think Prof. Moore covered it, but maybe you can answer it again, Prof. Moore.
Well, I think that that the results are more or less the same, and it's not a less invasive operation because you have got to do a laparotomy for both.
Yes.
So I suppose an anastomosis is more invasive. It is a more simple procedure, and a big advantage, of course, is that you can just pull the T-tube out when you don't need it anymore.
Yeah.
Whereas the others need an operation. I just want to comment on the screening. I think it depends on which population group you're dealing with.
Correct.
Certainly, the incidence in Black Africans is much lower. Now, whether that is the fact that we are missing them or the fact that their genetics are different, and I think it probably is the latter, that the genetics are different and therefore we aren't picking it up. But I just want to make the point that in Asian populations, it is 1 in 90,000. It is actually very, very uncommon. And again, it could be because of resources and diagnosis, but those are the figures that were given. So maybe if we're going to screen, we should be screening the highest incidence. And it's not that uncommon when you really look at it, depending on which population group you're dealing with. So if your practice is mostly Black and Asian patients, you probably will have a lower incidence. Whereas if you've got a Caucasian practice, it could be quite high. And just to say that there are about 5 genes that are commonest in South Africa. The Delta fiber 8 is obviously the number 1, and the figure I've seen is 2% of those screened have the Delta fiber 8 mutation. But there are about another 3 that have a much smaller incidence, somewhere around 3 or 4% in the South African patients. And then there are some specific genes that seem to be associated with Black patients, which certain laboratories can test for. And just to say about this is that of these 2,000 genetic abnormalities that have been described, not all of them cause cystic fibrosis. That's the problem with interpreting genetics. And you have to, these days, not just find a mutation, but you actually have to see the link and see where it actually fits into the biochemistry of the problem that you're looking at. So those are the comments that I wanted to make.
Okay, Prof, thank you. There's another question from Dr. Majola. I think Dr. Levy can answer that. What tests do we have at state hospitals for diagnosis here in East London or in Eastern Cape? Maurice?
Well, the sweat test is the gold standard for diagnosis. And we actually outsource it to a private lab because there are so few requests. A sweat chloride of greater than 60 is diagnostic, but in an infant or newborn, a sweat test of greater than 30 would be highly suspicious. I think now the immunoreactive trypsinogen is only valid in the first month of life. So we don't really do that. And then there's the stool elastase we can do. I think it's a send away, but certainly our main test is our sweat chloride, which
Yes.
we have available.
Yes, thank you, Maurice. That is freely available in private sector. But as you say, I didn't know myself that we can outsource it. We obviously have to take superintendent's permission and get it done then from the private laboratory. Yes.
Yeah.
Thank you.
I also wanted to just correct myself. The question about ibuprofen.
Yes.
It's the high dose that is used in cystic fibrosis, not the
Okay.
low dose.
Okay.
Yeah.
Okay. All right. Okay. I will now ask Dr. Yashoda Manikchand, our consultant pediatric surgeon, to make any comments, ask any questions. Yashoda?
Hi, Prof. Yes, thanks to everyone who's spoken and for all the experience from Prof. Moore and from Dr. Levy. We do get some patients with this inspissated bile, and we tend to do stomas or Bishop Coops for them. But I think it's important for us to know about the inspissated bile as well and the bronchial secretions, because I think we've had 1 or 2 patients who didn't get past the neonatal period and didn't get to testing, but we are definitely seeing some suspicious cases. And I just wanted to ask if we can do any of the genetic tests, because I know we have tried, but as I said, they didn't get past a stage where we chased up the results, and yeah, it wasn't actually done. I think it was sent to Cape Town or something. But yeah, are the genetic tests available to us?
I think again, Dr. Levy can answer that question, Maurice.
I wish I could, but I don't think so. Maybe at Red Cross they would be able to. Can Dr. Prof. Moore answer that?
Certainly, Red Cross can do it. Where they have it done, I'm not sure, but there are certain private laboratories around it do offer that as an option. Of course, you know, this business about sending to Cape Town is a problem, because things get lost, and it's not an answer in itself, and it just emphasizes the fact that we have to follow up all of our tests to get an answer. Chase people.
Yes, thank you. There is another question from Dr. Majola. I think Maurice can answer that. How is the sweat test performed? I know the answer, but I think Dr. Levy can answer it better. Maurice?
It's called iontophoresis, and it's putting a current on skin which generates sweat, and the sweat is collected in a little device, like a little circular tube, and yeah, and then you just measure the chloride.
Yeah, thank you, Maurice. I think Prof. Hadley has another question or a comment. Prof. Hadley?
Yeah, thanks, Melinda. I wonder if I can ask Dr. Levy, how often is the nutritional failure in these children? How often is it so severe that you refer these children for gastrostomies or for supplemental nutrition or parenteral nutrition?
We try and manage it using Creon, the pancreatic enzyme supplement. And these kids are, if we're lucky, they're underweight, but we hardly ever need to actually go the route of venous, but we certainly can give them supplemental feed. Yeah, but hopefully with the Creon, getting the right dose, that is the way to go.
Thank you. Can I just take this opportunity to thank everybody who's participated in this? So from Juanita, Professor Moore, Dr. Levy, I've learned a lot, and very grateful. Thanks very much indeed.
Maurice, thank you. I have learned from you that as the age advances, you need to go on increasing the dose of pancreatic enzyme. That's something, I mean, it's common sense, but that I've learned from you when I followed some patients or referred some patients to you.
Yeah.
Yeah. If Dr. Beda Espinosa is still here, he's from Philippines. So Beda, if you are here, do you want to make any comment? Do you at all see cystic fibrosis in Philippines? I think he may have left. Okay, no problem. I see there is Professor Chowdhury, who is from Islamabad, Pakistan. And Professor Chowdhury, any comment? Do you see cystic fibrosis in Pakistan? Are you still there?
Thank you. It's a nice presentation about cystic fibrosis.
Yes.
Actually, we very rarely see cystic fibrosis in Pakistan. It's a very rare of the rarest disease here.
Okay.
Maybe that's maybe underdiagnosed, or maybe it's less likely as the incidence is less in the in our nation, yeah, Asian population. But it's we stuck with the one case of a pediatrician, although it was on the enzymes, and at the age of 14 years, we have to do. We are unable to clear, although it was on the management, but we're unable to do clearance, and we have to go for the laparotomy. In the neonatal age group, we rarely see cystic fibrosis in Pakistan.
Okay, thank you. Thank you very much. Maurice, any final comments?
No, not.
No, thank you very much, Prof. Moore. Any final comments?
Just to say thank you very much for the opportunity. I've enjoyed it. I've actually learned quite a bit. And just about the sweat tests, it really needs someone who does a lot of them. My experience is that it's not just a casual test that you can do. It needs someone who knows how to do it and does a lot of them. Thank you very much for the opportunity of sharing in this video.
Thank you, Prof. No, it was really very nice presentation from Conita, and excellent medical input from Dr. Levy, and surgical input from Prof. Moore. And we all have enjoyed the meeting and the participation. I just want to find out, Dr. Majola, do you have any other comment, any question? You have asked lots of important questions, but do you have any comment? Dr. Majola, are you still here? No, sorry, your line is breaking.
No.
Okay. All right. Okay, so your line is breaking. So I'll just say thank you to everybody again. Thank you for all the participants, and we will see you next week. You may not see me, but there will be a presentation about blood transfusions, the common indications for transfusions, complications of blood transfusions, and ethical considerations of blood transfusions in Jehovah's Witnesses. So Dr. Kirsty Pedersen will present on that topic, and Dr. Mia Ilsen will be hosting the meeting, and Dr. Karen van der Berg, who is the acting CEO of the South African National Blood Service. She will be our invited guest. So thank you again. Have a good evening, and we'll see you next week. Bye-bye. Bye, Prof. Moore, and bye, Maurice.
Thanks very much, Milind.
Okay, bye-bye.
Bye-bye.